Okay. So, this is about the depression is very important in the Asian countries because in our custom we always sit on the floor. So
yes.
in our country sit in the so-called tatami, Japanese style floor, without shoes. So just like this one. So
Yeah.
we uh, have dinner or lunch with our
In
family
Myanmar.
in
In
Myanmar.
Myanmar.
This is
Oh, yeah, yeah, yeah,
in
yeah.
Myanmar. Yes, he's a Zanitun in
Yeah.
Mandalay. So maybe you know him and how
Yes, yes.
this
He's
is my
from
junior.
Yangon.
Yeah, Yangon. Yes, yes. So it is our custom. So deep flexion is very important. So because we have to sit on the floor and get up from the floor, and many
Yes.
reports said that. But
Yeah.
recently, many Western people also interested in Asian culture. For
Yes.
example, many tourists come to our hospital, no, our country, and go around and enjoy our restaurant or our custom. So this is another. This is a style of yoga. It needs some deflection. So the demand of deflection is increasing recently. So what angle do we need to get these daily activities? For this is a normal people. In the normal people data is still flat walking level walking. It's around 17 degrees. Ascending a slope and descending a slope around 17 degrees. And the stairs going up and going down the stairs around 100 degrees up to the 120 degrees. Sit down the chair, sit down, stand up from the chair is around 100 to the 110 degrees. Get in the bus and get out of the bus is more, we need more deeper flexion around 130. How about the post-operative? Pre-operatively, the limitation angle is very limited, but after that, we need at least 90 degrees. But I believe this is too small. We need more deeper flexion. For example, to flat uh, flat floor walking, level walking, we need around 6 degrees. And steer up and steer down, we need around 19 degrees. And climb up and sit, stand up and stand down in the chair, we need around 19 degrees. More smaller, for example, sofa or very short chair, we need around 110 degrees. And in addition, if the patient want to ride a bicycle, roughly saying the patient need to bend the knee approximately 120 degrees. So maybe the 120 degrees should be needed to do the daily activities. But how to achieve deeper flexion of someone's coming? Okay. Okay. So how to achieve deeper flexion? So rollback motion is necessary. So if there is no rollback, maybe the posterior edge of the polyethylene bearing will hit against the posterior wall of the femur, like this. If the femur move back, roll back the posteriorly, so we can get the enough space to get in this posterior edge of polyethylene and behind the posterior condyle of the femur. So we need to roll back to get the deeper flexion. Okay. In addition to rollback motion, we need to lateral condyle subluxation like this. This is a very famous report. So this is the medial side, and this is the lateral side. From the flexion to the extension to the flexion, the medial condyle move posteriorly around 1 or 2 millimeters. In contrast, lateral condyle will move posteriorly around 2 centimeters. So this is the 3D CT during the deepest flexion. Just like the Caesar, our style of sitting is, have a look. This is the lateral condyle. Lateral condyle move posteriorly, almost dislocated left like this. But in the medial side, the contact point is here. It is still on the mid part of the medial tibial plateau. So medial side of the condyle never roll back during the deflection. This is the difference. So that we need to get the deeper flexion, we need a rollback motion. But this is especially on the lateral side. Lateral condyle should move posteriorly. So just like this. So it is very very interesting. So in addition, if the lateral condyle roll back, so we can get the space here. This space is for the patella. So if the patella come here, so have a look, the patella overlap to the medial condyle. So patella can shift laterally. So it can shorten the quadriceps length. So if the patella come here without the lateral pivot motion, medial pivot motion, the patella come here. So the length of the quadriceps is longer than this situation. So to the deeper flexion is lateral condyle postural movement. Subluxation is mandatory. Okay, this is the MRI. This is the medial side. Medial side is almost contact at the same place. Here. Now some greatly move posteriorly, but this lateral side is 19 degrees in flexion, and this is the maximum flexion. This is almost subluxation, dislocated. So interestingly, this is the meniscus. Meniscus will move posteriorly along with the posterior condyle of the lateral side. So this is a contact point. So this is the contact medial side of contact point. So this is move not so many. So around this report, the posterior movement of the medial side is approximately 6 millimeter. But this is a lateral side from 19 degrees and 162 degrees. It's moved around 3 centimeters. It's incredibly long. And at 162 degrees, the lateral condyle is almost dislocated posteriorly. Interestingly, at this situation, the meniscus is still with the femur and the tibial side. It is very interesting. So meniscus will move posteriorly completely passively, and also it will change its shape, thickness, and width. Okay. In addition, in the flexion, 19 degrees flexion, lateral, this is the MRI in 19 degrees and apply the beta stress. In 19 degrees in flexion, the lateral surface are separated under basa stress. And this is the MCL. MCL is the tight. This is a normal knee. So this is the LCL is good length, its original length. It means in the flexion, the lateral loose is normal because the lateral LCL has a length for the lateral opening in the beta stress in 19 degrees flexion. So in flexion, the lateral gap should be loose. So otherwise, so it is too tight, maybe it can prevent the deeper flexion. So the relative loose lateral can lead medial pivot motion. So medial side is relatively tight and lateral side is loose. So femur can rotate around the medial condyle. In addition, this medial pivot motion can cause due to the articulation characteristics. For medial side, tibial plateau plus meniscus makes the concave shape, just like the TKA, the ball-in socket, something like the ball-in socket. Of course, it is not perfect. But on the contrary, lateral side is relatively flat. But this one, lateral surface of lateral eminence, lateral tibial spine, and the medial edge of the lateral condyle can make the articulation. So that also induce a medial pivot motion. It is really, really important. But in the later way, everything comes loose. For example, medial side, medial collateral ligament is loose, and meniscus excursion, then femur move medially. We call it lateral thrust. So it can cause the wear of this part. This is the beginning of OA, or the cartilage defect. We start here due to the meniscus excursion and the slightly medial movement of the femur on the tibia. In addition, this tibia will hit to the lateral tibial spine. At the beginning of the disease phase, the cartilage here, medial edge of the lateral condyle, can cause defect wear of the cartilage. This is another characteristic of the OA knee. Anyway, this is quite important to do the medial pivot motion. In addition, the size of condyle is different between the medial side and the lateral side. Medial side is larger, in radius, and the lateral side is smaller. So please imagine the ball. So these balls rolls simultaneously. They can cause the curve because lateral medial side is larger and lateral side lateral side is goes around the medial side, and this articulation also the medial pivot motion. But how about the TKA? How can we induce the posterior movement, posterior roll back in the TKA knee? There are two policies. Sorry. This is due to the PCL tension. During the flexion, due to the posterior pull, pulse of the PCL, that pull the tibia, femur posteriorly, then roll back will occur. So similar to the native motion, this is a completely similar mechanism to get the posterior movement of a femur on the tibia. This is a CR knee, concept of CR knee. In the CR knee, the PCL will pull the femur posteriorly during the knee flexion. In contrast, this is a post-arm come, the guided motion. This is a PS knee. In the PS knee, like this, this come will hit with post like this. This post will come, push the come posteriorly. Then, as a result, the femur go back the posteriorly. Now we call it a guided motion. This combination of come and post will decide the kinematics. But this kinematic should be different from their original kinematics because this movement can be decided by the design of the post and the come engagement. And on contrary, this in the CR knee, this posterior movement is depend on the function of PCL. If PCL is too tight, so of course it can lead the posterior movement, but posterior gap in the flexion will be tight. It can cause abnormal stress. Then subsequently that can cause the decrease of the deeper flexion. So to achieve the deep flexion, so many components have deep flexion component. This is very famous next gen. This is a normal design. This is the high flexion design. The difference is thicker posterior condyle like this. So it means if he cut the posterior condyle more and replace with the metal, so we can control the contact point between the femur and the tibia. But this is a very thin posterior condyle. So, but it can cause point loading in deep flexion. But if we replace the metal here, we can make this part more rounded, and a little bit rise up posterior limb can articulate sufficiently even in the deep flexion that can prevent the point loading and the severe mechanical stress in the maximum flexion. And low engage point is lower. So this is the engage point here. So this can act the significant load from here. But in the deep flexion, in the design, the contact point is engage point is here. So that can reduce the mechanical stress between the tibia tray and the bone. It is the effect of the lever arm. So lower contact can decrease the stress. Okay. So another important point is preoperative condition. This is our data. So postoperative flexion is greatly influenced by the preoperative condition, such as soft tissue condition, for example, native elasticity of the soft tissue. For example, in a male patient has the very strong, less elastic soft tissue, but in the female patient, especially very thin female patient, the soft tissue is very elastic, so it can easily elong. So this is the very beneficial for getting the deeper flexion. So this is a patient condition. So this is a soft tissue characteristic is different among the patient. And in addition, disease progression can cause the difference, the pre-operative condition. For example, contracture, that means the tightness or shortening of capsule, or ligament, or muscle, and even the fascia. So, in addition, the make osteophyte formation can cause the impingement. That also can prevent the depression in the preoperatively. So if the osteophyte hit to each other, so the extension or flexion should be limited. In this condition, soft tissue will shortened, contracted. For example, many patients have the anterior osteophyte on the tibia plateau in front of ACL insertion that can hit to the trochlea of the femur during the full extension that can cause a pitch flexion deformity. In this condition, posterior capsule can contract it. So after the implantation of the UKA, that can preserve both ACL and PCL in this condition. Even we remove anterior osteophyte, the full extension cannot be achieved due to the posterior capsule tightness. But it will along to their normal length in 6 months or 1 year after the operation. So, in summary, the osteophyte can cause soft tissue contracture as well, and deformity. This deformity means angular deformity. For example, the very severe varus deformity and severe varus deformity. So this can cause the collateral tightness. For example, the Vargas knee, very severe Vargas knee, the lateral contracture is obvious. So we need to detach or release the lateral soft tissue, such as ITB or LCL. In contrast, medial side OA, especially the patient has a severe bone defect on the tibial side, the MCL will shrink and contract in the grocery. So in the case, we need to detach or release the MCL. Anyway, this is deformity can cause the limitation of the flexion and the pain. So pain also can cause the limitation of the ROM. So, preoperative RM is very important factor to predict the postoperative flexion angle. In addition, opposite side of RM can affect the postoperative flexion of the operated side because the knees tend to go to the same RM to the opposite side knee. If the opposite side is flexion is very well, the opposite side knee tend to flex deeply. On the other hand, on the opposite side is knee is contracted. For example, the right side is operated side and the left side a previous TKA knee. That has only 19 degrees in flexion postoperatively. After the operation of right side knee, even for the UK, the right side knee tend to be limited the deep flexion approximately 90 degrees. So opposite side RM is also important. And of course, six, gender is very important because female patient has very elastic soft tissue and flame, and body weight and height can influence the postoperative flexion. This is the relationship between the pre and postoperative flexion angle. That they have a very weak positive correlation. That means the patient have good preoperative flexion angle. The patient can get a little bit deeper flexion angle, but this correlationship is not so strong, very, very weak. But interestingly, so preoperative flexion angle is significantly correlated with change in flexion angle negatively. This is a negative, strong negative correlation. That means if the patient has the deep flexion preoperatively, the patient will lose the flexion angle postoperatively. And the patient has the limited flexion angle preoperatively, the patient can get the deeper flexion angle. This cross point should be around 123 degrees in your report. So this is very interesting. So we can predict the patient will get or lose the preoperative flexion angle. Depend on their preoperation flexion angle. And in addition, opposite side is positively moderately correlate with the postoperative flexion angle. That means if the opposite side knee flexion is good, the patient tend to get the deeper flexion angle. So we need to check the both preoperative and postoperative flexion angle. But however, the height, sex, and weight and age do not correlate with the postoperative flexion angle by the multiple regression analysis. Only the opposite knee flexion and preoperation flexion is high impact factor that influence the postoperative flexion angle. So another important concept is posterior condyle offset. So posterior condyle offset PCO, that means the distance from the posterior lower point of the posterior condyle and the posterior cortex, this distance. If this distance is small, the posterior edge of the bearing can hit against the posterior wall, posterior cortex of the femur in the early flexion phase. So, but if we get enough distance from here to here, the knee can bend without impingement between here to here. So this is the good relationship between the postoperative minus postoperative condylar offset, the PCO change. This is the change in flexion angle, the flexion change between the pre and postoperative flexion angle. They have the positive correlationship. That means if the patient gets the bigger PCO postoperatively, the patient can get the deeper flexion angle postoperatively. This is also very interesting situation, but it is quite difficult to control this PCO because big PCO can cause the tightness of the flexion gap during the flexion. So this is a contradiction of the long PCO and the flexion tightness gap. Okay, I will talk about this one in tomorrow. Okay, do you have any question?
Oh, thank you, sir.
Any question? Okay, I also upload this presentation later to the YouTube so you can see again and again. So if you have any question or some difficulty to understand, please inform me. I will explain. Because as I said before, I'm in the long holiday in Japan until tomorrow. So I have enough time to answer to your question. Okay?
Okay, thank you. Thank you, Professor.
Thank you. Arigato. See you tomorrow. Thank you.
See you tomorrow.